of experience with more than 3 decades of teaching experience. Because whenever we talk about Dr. Gopinath, there will be lot of followers, students across the state. They will have such a strong fanfare for Dr. P.M. Gopinath. Doctor is practicing infertility, endoscopy and ART. And now today's topic, I'm sure will be very interesting and useful for all of you. And now I hand over to Dr. P.M. Gopinath for taking over the session on surgical strike in male infertility. Thank you very much, doctor.
Good evening. Good evening, Balaji, and good evening all my friends who have been with me in the previous part, and they have just requested me to continue with the surgical management. Balaji?
Ramanan?
Sir, yes, sir.
Can you able my to do screen share?
Sir, you can share the screen, sir. There is a button called share screen.
No, it says host disabled participant screen sharing.
1 second, 1 second, 1 second. One second, doctor. I'll just. Doctor, now you check, doctor. Now it is.
Yeah.
You are able to see. Doctor Gopinath, this sharing varliya.
Somebody else is thing it.
No?
Okay.
And now it's okay. Now start right. Okay. Right, man. Thank you.
Okay. I think we'll go ahead.
Yes, doctor.
Good evening, everyone. And we'll be covering today. We'll be covering procedures in male infertility, and especially sperm retrieval techniques and preoperative optimization before the sperm retrieval, laboratory processing of the retrieved sperms, sperm selection methods, and then we will conclude. To give an introduction, I know that all of you are very familiar. There are about some 1/3 of the infertile population is purely male, and then 1/3 is female. The remaining 1/3 is mixed. So probably you will have about 50% in male infertility. If you take the male infertility, we have no sperm category, and we have low sperm category, and we have normal sperm category. So probably you will see more than 15% will be a low sperm, 10% will be something like no sperm category. So we would like to see, and in the first half we have seen the medical management, how much we can just do and what are all the chances, what are all the drugs and how much we can just anticipate the results. Now we'll go to the surgical procedures. So if you take a Ramanan,
Yes, doctor. Yeah.
I'm not able to move the slide.
No, you, have you started that slideshow, doctor?
Yeah,
That
area
slide
to be,
was
are
there.
you seeing the slide?
Yeah, I'm able to see first slide, areas to be covered.
Areas to be.
Click on that slide, doctor.
Then after that, I am not able to. Then I am not able to move the slide.
Just stop it again. You start the share, doctor. Just able, you are able.
Okay. Yeah. And now the first important thing, the surgical procedures in male infertility, we will be talking about testicular biopsy, varicocele surgery, and other obsolete procedures which has been done long time back. And I will also explain why we have been doing it and why we are not doing it now. And then we will talk about the sperm retrieval procedures. And the first and foremost is a testicular biopsy. It is a simple office procedure performed under local, sometimes general in case if the patient is very apprehensive, or we can do it with an IV sedation supplemented with the local, we can just do it. But the more important thing is it should never be done with formalin solution. So we have to prepare a separate solution, what is called as Boyne solution. This is nothing but the picric acid, acetic acid, and a small amount of formaldehyde. Because if you put formaldehyde, it hardens the tissue. You will not be able to do anything, or you will not be able to do a microscopic study. So that is the reason, in order to soft pedal there, we have added picric acid and acetic acid along with a small amount of formaldehyde. That is a Boyne solution which has to be taken and used it for testicular biopsy. But the more concern here, it disturbs the blood testis barrier. So for example, if it is a case of oligoasthenospermia, if you try to do this, and ultimately you might break it, there may be an antibody formation, and then it might further retard the prognosis. So you will never do a biopsy for severe oligoasthenoteratospermias there. So that is a message. How do we interrupt that? When you do a biopsy, active, there is full spermatogenesis confirms it is only an obstructive azoospermia. When the man is not able to produce, you do a biopsy. If there is a full spermatogenesis is there and it confirms obstructive azoospermia, these are all the candidates potential for surgical reconstruction. And then in case if there is an absent or arrested spermatogenesis, for example, it is only Sertoli cell syndrome or maturation arrest or hypospermatogenesis, here again it confirms non-obstructive azoospermia. So if these are all the candidates who can undergo testicular sperm extraction or micro TSA. And interpret the histological patterns of the biopsy with caution, because if you do it from one side, it may not universally reflect the other side, and sometimes there will be an area where it will be normal and there will be another area where there will be an absent sperm. So we have to carefully see and then take the biopsy and do it out. What are all the indications for doing a testicular biopsy? You see here from the American Urological Association, they say testicular biopsy is not necessary for diagnosis or prognosis of non-obstructive azoospermia. So that is the testicular atrophy or markedly elevated FSH level. Patient who have a normal FSH level should undergo this kind of a procedure, and it ensures that there is a presence of spermatogenesis. You should not make for a diagnostic purpose. You should not do it. That is the important thing. And do not do the biopsies for severe Oates cases there. What are all the complications for doing the testicular biopsy? One, there may be a bleeding, and it is minimized with the use of operating microscope or surgical loops there. And there may be an infection, either testicular arthritis or scrotal abscess. There may be a pain, testicular arterial injuries from the cord block when they give it from the anesthesia point of view, or it may be an inadvertent epididymal biopsy. When you just take it, it might just go on bleeding at that particular site. What can happen? They can go in for a hypogonadism, depressed or testosterone levels, depressed spermatogenesis. So particularly if the artery is injured, these are all the complications of this. Diagnostic biopsy is more or less practically, it has become obsolete. We have started doing it only for the sperm retrieval techniques there. So the testicular biopsy, the important diagnostic test in the evaluation, it provides definitive histological diagnosis and it aids in the management of the clinical condition. Further, the importance with assisted reproductive technology, it is very, very useful for prognostic information for sperm retrieval. Now we will come to the next surgical entity, that is a varicocele. It is usually present in about 15% of all men. That is number one. And it is present in about 35% of the men with primary infertility. And then it may be present in 80% of the men with secondary infertility. For example, you will see here 23% varicoceles are large. 3% of all men, whether fertile or infertile, might have a large varicocele. Generally, the large varicocele cause severe impairments in the sperm quality, and then they also depress the testosterone production there. Repair of a large varicoceles may result in a greater improvement in the semen quality and improvement in testosterone production there. How do we make a diagnosis of varicocele? It is very, very simple. You should ask the man to stand erect, and then with a good lighting, you just visualize there. The inspection, palpation, and then on a relaxed scrotum. For example, in the cold countries, they just say you have to have a good temperature, because if there is very cold, it might cause constriction, and then you may not be able to make a diagnosis. Whereas in our country, it does not do so. It is easier to just palpate them, and then it will be like a bag of worms. It will be actually seen, as you see in the picture. This is a grade 3, and very, very rarely you might encounter that Doppler and high resolution ultrasound, both upright and supine, and with the Valsalva maneuver. So why do we need all this thing? It is purely for documentation prior to the surgery, and after properly explaining them what are all the consequences, what are all the results you can expect out of this surgery there in varicocele. And you will see that the grade 3 varicocele is easily visible through the scrotum. And grade 2 varicocele is palpable at rest without Valsalva maneuver. Grade 1 is, it's palpable only with Valsalva maneuver. When you see that, you may miss it. But when you palpate it and then ask him to do a Valsalva maneuver, then you will be able to see that. So if you take grade 1, 2, 3, grade 3 definitely needs attention. We will come to that, how it is important there. There is another entity called subclinical varicocele, where the veins are less than 3 millimeters on ultrasound, whereas when you do a Doppler, you will be able to demonstrate the varicocele. So the use of varicocelectomy in subclinical varicocele has been well documented from an Italian study where they mentioned it does improve the results. However, we do this only in cases of grade 2 and grade 3 there. What are all the ideal candidates for doing a varicocelectomy? Men with oligoasthenospermia with a palpable varicocele, that is grade 2, and especially large varicocele. As I mentioned it earlier, it is seen in about 3% of the men. And then if you do that, immediately the there will be a reversibility. That is, spermatogenesis will revert back to normal, and then testosterone productions will be normal. The boys with large varicocele and testicular hypertrophy, that is, when you look at the testis volume, if there is a disparity between these two testes by about 2 centimeters and 2 millimeters, then you know that there is a 2 cc volume. When it is less than that particular site, if there is a varicocele, that needs your attention. There are some other indications for varicocelectomy. Men with non-obstructive azoospermia with a palpable varicocele. If you do a varicocele repair and then do an aspiration, then your chances of survival will be, their retrievals will be better. Men with largest varicoceles with low testosterone level, you do that, the testosterone level will bounce back to normal. What is the effect of this varicocele on infertility? The varicoceles may cause a progressive decline in fertility. Prior fertility in men with varicocele does not predict resistance to varicocele-induced impairment of spermatogenesis. Men and adolescents with large varicocele may benefit from prophylactic varicocelectomy to prevent future fertility and possible testosterone deficiency. For example, a man who has got one child, planning for the second one, oligoacinospermia and mild erectile dysfunction, and then low testosterone level with the varicocele, the simplest thing is to do the varicocelectomy, because you may get a baby, you may offer him a baby, but definitely the testosterone will bounce back and he'll be much more satisfied person there. Now, how do we approach this varicocelectomy? So there is a microscopic inguinal or subinguinal approach where you make a small incision about 2.5 centimeters on the subinguinal, maybe directly on the inguinal canal, open the roof of the inguinal canal, take the entire cord structures, do a loop, and then isolate the vas and then artery to the vas, and then take the veins either in one bunch or in separate bunch, you can do it, and then you close the roof back again and then do it. There are some recommendations with the use of a Babcock forceps. Gradually you can dilate and even remove the testis and then see, and then you can ligate the gubernaculum veins also through the same incision, and it has been documented there. The other approach is retroperitoneal, what normally we have been taught of as a Palamos approach. And then there is a conventional inguinal, just like any other urologist, where you do a very wide urological incision and then try to do and preferably when you are trying to repair a hernia, you do a conventional. The next is the laparoscopic approach. The laparoscopic approach is very, very handy, very novel. We had somebody from Singapore who presented about 1,000 cases of laparoscopic varicocelectomies. However, the big point here is the cremasteric veins are again the culprits, which you will not be able to access through the laparoscope. So the chances of recurrence following a laparoscopic varicocelectomy will be very high. So that is the reason, so you will be able to do it. Again, when you do a microsurgical repair, you will see that incidence of hydrocele following the repair is 0.2%. Against a conventional is about 3 to 30% because you may damage the lymphatic drainage there. So this is something like a very small incision. You make a small retractor, make a nick on the anterior, and then use a Babcock forceps, take the entire cord structures in your hand, open the cremasteric fascia, then you will be able to see the veins, and then you isolate the vas, and then artery to the vas, and then you will be able to ligate it there. There are some other benefits of varicocelectomy. What are they? One is sperm parameters significantly improved. That's what we have just mentioned it. Oligoasthenospermia definitely improves. The second important thing is sperm DNA fragmentation significantly decreases. For example, you have a person whose count is around 10 million and you keep on doing that IVF and ICSI where you develop into a recurrent implantation failures or recurrent pregnancy loss. So probably you look into the DNA fragmentation fragmentation. If it is very high, you do a simple varicocelectomy, then you will be able to improve the DNA, decrease the DNA fragmentation, thereby improve the pregnancy rate. IVF in ICSI in treated and untreated varicocele. So they have seen it. Infertile couples which has male clinic and varicocele. Clinical pregnancy rate when you treat varicocele and then take the patient for ICSI, it is 60% against 45%. The live birth rate, you will see that 46.2% against 31%. So if you have a documented varicocele, it is better to do a varicocelectomy and then take the patient for ICSI to improve your results. To summarize on varicocele, microsurgical repair of varicocele is cost-effective treatment of male infertility, can treat androgen deficiency also. It can prevent future infertility when you're trying to do it in a younger adolescent boys. It can prevent future androgen deficiency when you're trying to do it on a men. There are some other surgical procedures. The first is the vasoepididymal anastomosis. When you have a bilateral vasal obstruction, we just try to chop off the end at which where you see the vas, try to connect it through the epididymis on the hole by making a vertical incision. And then subsequent to that, they have seen it, it has been closing and it is not open. The sperm appearance rate was much lower. So what they have just taught, Silver and other people, they worked on it and then bought it as a single vasal anastomosis. Open the epididymis, under the loop you examine whichever is one large vase where there is some secretion, that is a single vase, is the vessel is anastomosed to the vase. So that anastomosis had a better results. And then in case of previous vasectomy, vaso anastomosis have been done. Of all this, probably the vasovasal anastomosis still has got a good place to go in the previous vasectomized individuals. The last one is an artificial spermatozoal creation. When you have bilateral vasal obstruction and when there is a good performing testis is there, those days in the pre-IVF era, when I started my infertility practice, we used to take a tunica vaginalis testis and create an artificial spermatozoele, allow this collection to take place. And then somewhere close to that ovulation, we will do an ultrasound, take a needle and then aspirate the contents and then try to just wash and then do an insemination. So these are all the procedures, almost all the procedures except vasovasal anastomosis has become outdated in the event of this ART procedures there. Now we will come to the sperm retrieval techniques there. What are all the sperm retrieval techniques? Here, the sperm retrieval techniques are surgical methods that have been developed to retrieve spermatozoa from epididymis and the testicles of azoospermic men. So here, your most important thing is after the sperm acquisition, the intracytoplasmic sperm injection is used as a standard method. You cannot aspirate it and use it for IUI and other procedures. Ideally, it should be used only for ICSI, not even an IVF there. So this is the procedure. What are all the indications for operative retrieval? So retrieval of epididymal or testicular sperms for ICSI. Here, obstructive azoospermia, when the reconstruction has failed or you don't have a proper person, you have a better ART services with which you will be able to give a better results, we can directly go in for sperm retrieval. Non-obstructive azoospermia, men who have focal spermatogenesis. I'll just come to that when I try to talk about the particular procedure. Yes. And then there is a high DNA fragmentation when it is present. Then the testicular sperms will give better results when compared to that. Severe oligoastroteratospermia again is one of the indications where we'll be able to just do this sperm retrievals there. There are some candidates for TISA, and here you will see that testicular failure, Klinefelter syndrome, Sertoli cell syndrome, post-chemotherapy, especially in a lymphoma, cryptorchism, maturation arrest, previously failed attempts and biopsies where we can just plan that. Now you will see that picture here. There are two pictures which is shown here. One is PISA, another one is TSA. PISA is something like just take a small scalpel set, introduce from percutaneous, try to aspirate it into a syringe with a culture medium, and that is the TSA. Where TSA is where you cut open, take a small bit wedge of the testicular tissue, and then try to do that. What are all the goals of our sperm retrieval techniques? To obtain adequate number of high quality sperms, which you can use it for an ICSI, with which you should be able to get a good embryo. By the same time, you have to minimize the damage to the reproductive tract. Thus, you should not go in for repeated retrieval attempts. You try to use a small portion and then just cryopreserve the rest of the portion. What to do before retrievals there? Is there any role of prediction testing before to say how much you can do? The patient and you should be on the same page when you go for the treatment. Patient should not understand 100% she'll get a baby when you put a knife on the testis, and you should not also think that definitely I'm just going to result. So there are some predictions are available. Then is there any role of genetic testing? Do we have to do a genetic testing before sperm retrieval? And what is the role of diagnostic biopsy? And then lastly, is there any medical treatment to improve the success rate of retrievals? These are all the points which we'll be taking here. The potential predictors here, you will see here, testicular volume. A normal volume testing shows probably there is a good spermatogenesis, you will be able to take the good sperms out of them. Follicular stimulating hormone is about 5 international units per ml, and if you feel it is increased to 2-fold, then you are losing some time. If it is increased to 3-fold, your chances are going to be very poor. Luteinizing hormone was used, but however, it is not being used in the practice day. Testosterone, inhibin B, and genetics testing. So these are all some of the predictors. Now let us see, neither a single factor nor a combination of this factor satisfactorily predicts the sperm retrieval. So these are all the factors you can consider, but you will not be able to use it. Now here you will see there is in a fertility sterility, there you will see here, they have done a huge 29 studies involving about 4,760 patients. They have taken FSH, LH, testicular volume, and testosterone was tested. The conclusion there, FSH alone can be a predictive of retrieval of success used to counsel the patients. There is only with that FSH you will be able to counsel the patients. There is also another paper which has just come out saying that you can do an ultrasound, fine ultrasound, high grade ultrasound with a very special ultrasound. With that you see a grayscale image by an testicular ultrasound showing a highly useful for predicting a sperm retrieval when you have a microRT in a large series. They have done it, they have measured it, and whichever has got a wider one, the success rate was better. Then another important thing is genetic testing. You know that there is a Y chromosome. So if you take the Y chromosome and a long arm there, there is a zone that is there is a centrome is there. After that, there are 3 red zones as it is seen in the picture. One is AFZA, another one is B, the other one is C. So this 3 zones has to be tested there. What is the implication? If the A is deleted, it shows it is germ cell aplasia. You will not be able to retrieve the sperms. So in a non-obstructive azoospermia, if the patient is doubly sure what are the chances, you have to do this and then see that A is not deleted. For example, if the B is deleted, that shows there is a maturation arrest. So no retrievable sperms there. So if both A and B are deleted, you will never be able to take a sperm in the retrieval technique. So you should not do it. However, if C alone is deleted, there may be a hypospermatogenesis, 70% chances of retrieval. Now you will see that if you have an individual who was asking about the prognosis, you do this simple test with which you will be able to see. If there is no deletion, it is again less than 50% chances. If C is deleted, 70% chances. A and B are deleted, do not touch the patient. So this is the implications of genetic testing there. Who should be offered this genetic testing there? Azoospermia. Before you do that, definitely you can do the testing. Men with sperm concentration of less than 1 million, you have to do a Y chromosome testing there, and then you have to do a karyotyping also with them. If there is an absence VAS there, bilateral absence of VAS, then you have to just look for the CFTR gene, which is very, very important there, cystic fibrosis testing gene. Now you just look at that scenario, sperm of less than 5 ml, then you do a Y deletion, karyotyping, and then don't do a cystic fibrosis. If there is a no sperm, azoospermia, you do a Y chromosome microdeletion and then karyotyping. And when you have an idiopathic obstruction, and absent VAS there, directly do only a cystic CFTR gene, and then you can just proceed with that treatment there. So in case of Klinefelter's, again, you will see that there is a reduced volume. It might be less than 6 cc's there. There is an increased gonadotrophin level. Both FSH and LH will be elevated, low testosterone level, and it might be azoospermia. So previously we thought if there is a Klinefelter, we always tell them to go ahead with only a donor insemination. Here you will see that what they have done, they have just given a medical treatment. They have 68 non-mosaic Klinefelters with azoospermia. The medical treatment was they have given an aromatase inhibitor, HCG, clomiphene citrate. You will see that the positive response was increase in the testosterone level, and which is more than 100 nanogram per deciliter from the baseline. So this again was a good response, which the pre and post treatment, which shows that this probably has got a role in it. Now again, stressing back, this slide I've just shown in the previous time, the medical management prior to the sperm retrievals in a non-obstructive azoospermia, look at the testosterone level. If it is less than 300 nanogram per ml, that shows it is hypo. So if it is in hypo, look at the estradiol level. If the estradiol level is less than the total testosterone estradiol level ratio is less than 10, it shows there is an hypogonadism, probably because of aromatase hyperactivity. There you can use anastrozole for some time, and then you can take the patient for ART. Again, if you look at the ratio, when the ratio is more than 10, then you know it is a pure hypogonadism, where you can do a recombinant HCG, or you can use a clomiphene and then take it. So these are all some of the ideal way in which you can just try for a thing. Surgery prior to the retrievals with the clinical varicocele there. I have mentioned it earlier. When you do a ligate the clinical varicocele prior to the sperm retrieval, there is a significant increase in the chances of the test. So, but you have to give minimum of about 6 weeks prior to that. So you cannot do simultaneously. Do a varicocele ligation. After 6 weeks, do a sperm retrieval, and definitely you will be able to get a better survival there. What about the role of antioxidants before the retrieval there? You will see that the sperm DNA fragmentation has been recognized as a factor for determining ART outcome there. So when you just try to do the, when there is an oral and in vitro utilization of the vitamin E and C to lower the sperm DNA fragmentation levels, then probably you can use it there to bring down the level before you take the patient for ART. There is no adequate studies regarding the role of improving the medical treatment. That is the reason antioxidants is never there. There is an FSH cutoffs level where they have just mentioned it. 90% men with a non-obstructive azoospermia, when the FSH was more than 7.6, the chances of when the long axis is the testis volume is less than 4.6, chances were very poor there. High FSH and the small testis, azoospermia, likely to due to the production defect, so no direct biopsy is needed. You can try to for a microtesia there. So you have to counsel the patient before you proceed. How do you counsel the patient? So you have to take a consent, document at each and every step, because the patient is desperate. They come to you for a procedure, but they fail to understand the procedure is not 100%. So you have to explain to them what are the chances, what are all the predictors. So from the predictors, how much is the chances? If by chance, if there is no hope, what do we do? For example, ejaculated sperm, you are trying it after varicocelectomy. If the quality is very poor, you might take it for a TISA. And in the TISA, if the quality is very poor, again, you will be able to just take it, try to preserve that sample and then freeze the eggs and then decide later, or you can just do a donor insemination. So these are all the points which we have to just explain to them, anticipate all the options, address it, and then you have to just take a counsel. You cannot be running from door to door to see them there. See, these are all some of the sperm retrieval techniques there. One is PISA, which is percutaneous epididymal sperm aspiration. So if it is a case of obstructive azoospermia, you can just use this. How do we do that? You take a small syringe with a culture medium, gently inject it into the percutaneous epididymal sperm aspiration. What is the advantage? It is a very simple procedure. Disadvantage, you might disrupt the normal anatomy. There may be an infection and you may not be, it might worsen, and then you may not be able to just do it for the second time. Microsurgical epididymal sperm aspiration, MISA, is again useful for only an obstructive azoospermia. Testicular sperm extraction, you can do it for in cases where it is favorable histopathology is there in the previous thing, you will be able to do that. The extraction is where you just cut open, take a small bit of the tissue and then give it to him, ask the embryologist to dissect it into pieces and then centrifuge it and take the sample. So microsurgical testicular sperm extraction, don't be carried away by the word micro. Micro is not, it's only a microscopic using, but the incision will be macro. So in a testicular TSA, you might put an incision of only about some few millimeters, let's say about 1 centimeter incision maximum you might put it. Whereas if it happens to be a microsurgical testicular aspiration, you have to completely divert the testis outside and bisect the entire testis and look under the microscope, and then you have to do it. So that means it will be a wider incision. So the testicular sperm aspiration is shown there in a picture. That is the least invasive. The next is a testis sperm extraction, where it's a small incision. Here you will see that microTSA, it's a very most invasive procedure. It's completely opened up. So you have to understand, micro is a misnomer here. It is a microscopic TSA. And in a case of an obstructive, you can use either a percutaneous, or you can use a TSA, or you can use any of the sperm retrieval techniques there, which I have just highlighted there. In case of an obstruction here, you will see that these are all the cases where you will be able to retrieve. In a genetic cases, it's about 100% success rate is there. Vasectomy cases, again 95%. Post-infection, again 100%. So this is the obstructive azoospermia, the success rate there. In a non-obstructive azoospermia, here it is an untreatable condition. So the testis may be very small. So here the microsurgery definitely scores over the conventional. You will see that under the microscope, you will be able to see the area where you will be able to take the sperm and then try to do that. This is how you see. It is something like looking for a needle in a straw. So in this particular area where there is no activity, here there is an activity from which you will be able to do it. This is how it will appear on the dilated tubules from which you will get a sperm, and this is the area from which you will not get a sperm. So these areas will be pointed out by using a microscope there. This is again a picture to show how it looks like in the picture, where this is the area where you will be able to get a sperm. This is the area where you may not be able to get a sperm. So you can compare microsurgical versus a single TSA used there. You will see here single biopsy TSA, and in all these cases, maturation arrest, hypospermatogenesis, overall 45% you will be able to take it out of the micro TSA, whereas only in 25% you will be able to do it in a single biopsy. So this is the prognostic factor, you should keep it in mind. So there is a sperm recovery rate from conventional testicular sperm extraction and the micro TSA. They have done a meta-analysis. The conclusion was it is definitely superior. But can you do it in all patients? Number one, you should have a good microscope. And number two, you should have a good personnel. Number three, you should be able to spend more time. So if you do a micro TSA, probably you might take about 2 hours to 2.5 hours. Whereas you do a TSA, you will be able to do it in about some 5 minutes. So this is the importance of the procedures here. Now, when you take the laboratory processing, the sperms retrieved may be performed either on the same day. Ideally, the best is to do it on the same day of the oocyte retrieval. Sometimes, if you are not sure, if you have taken it earlier, and then they may be having it, you have to just remove the contaminants, cellular debris, RBCs, and then all of them has to be just removed. After processing, epididymal and testicular sperm can be used for only a ICSI. So the PISAs, you can use various sperm processes are there with which you will be able to identify the good sperm. And there are, you will see that once when you just take the bits, use the iris scissors, cut the tubes. Always be sure you will never cut the sperm. So you cut the tubes into smaller pieces and then centrifuge it and then look at the microscope and then you will be able to get it. What are the complications of the sperm retrieval techniques? There is, it may be an intratesticular hematoma, pain, and then swelling, infection, sometimes hydrocele formation because of the lymphatic blocks. There may be a potential leakage of the blood testis barrier, permitting immunization towards the sperm. So there may be an antibody formation that might take place in the subsequent procedures there. The most complication usually resolves spontaneously without any compromise the testicular function. Androgen production will be normal. Extracting a large volume of testicular parenchyma may lead to a permanent decrease in the testosterone level. So you take a small wedge with which you will be able to do it and then store some of them. Incidence of complication is lower following a micro TSA than the conventional TSA, because under micro TSA you will be able to identify all the blood vessels and then you will be able to really just make an adequate hemostasis. You will see the advantages and disadvantages. TSA is very fast and low cost, and the disadvantage, the cryopreservation is got very limited. MISA, a large number of sperms you can do it, but disadvantage, it is an increased cost because you have to take them to the theater IVF OT. TSA is very fast and low cost, and then here success rate is low, particularly in a non-obstructive azoospermia. Risk of hematoma and testicular atrophy is there. TSA is again no microsurgical expertise. You can very rapidly do it. You don't need a thing. Micro TSA, you need a microscope. It's a time consuming, and then you should need have an expertise. Again, when you process the sperm from which when you take it out, you immobilize the sperm, cut the tail, aspirate into the tube, do an ICSI with which you will be able to achieve a fertilization. There are some way in which you can just select the sperm, which are the ones which you can just use it. The one is hypoosmolar swelling test. Here you will be able to identify the viable sperm for ICSI among the immotile sperms when you just take it. The sperms with the intact membranes and will swell in the hypotonic solution. That sperms will not show any changes there. So with these changes, you will be able to have that. Now the great advantage is when doing an HOS test, immediately you are able to use it for ICSI. There are other methods like magnet activated sperm sorting system, and then physiological ICSI by using an hyaluronic acid, IMSI, using a microscope, PICSI and IMSI, what we call it as a PIMSI, and then microfluidic technique. So we will see here the magnetic activation. What actually it attracts and just takes away the DNA fragmented sperms, and then because of that, what comes out of the column will only be a normal sperm. And the IMSI is again it is under a high magnification. You do it. It's a time consuming. You need a lot of expertise, and then with which you will be able to just do it. So that is the important thing. In the IMSI, you will see the pictures here. This apparently looks normal. When you under magnification, you will see here there may be so many defects which with it you will be able to discard and take the best sperm to do a procedure. So this is what they see. The PICSI is you take a hyaluronic acid and then make a small line in the petri dish. When you put all the sperms there, good sperms will come and get adherent to that hyaluronic acid in a falcon petri dish, and from which you will be able to take out and then use the sperms. And microfluid is again a very useful method where it is something like a small disposable kit with which you will be able to see that. This is the column. So here what you do is you put a 7 sample here, you put a culture medium here. So there are the 2 outlets are there. So with which you will get a good motile sperms, and then you will be able to take it. It's about roughly around 7,000 to 8,000, which is very, very useful there. Lot of work is being done on the microfluidic there. So what about the outcomes using the retrieved sperms there? The clinical data available is suggesting they have no impact about the success on the impact on the success rate in non-obstructive azoospermia. Risk of congenital malformation, the infertility and diseases in the children by using this surgically retrieved and sperm for ICSI is still poorly determined. We are not very sure it is increasing or decreasing. To conclude, different surgical methods and microteas are spermatozoa from either epididymis or testis along with the type of azoospermia. The choice of sperm retrieval techniques and its success depends upon the type of azoospermia, infrastructure available, expertise, manpower available. With that, you will be able to decide. Microdissection TSA more effective for select patients, not all, for select patients. Thank you very much for your patient listening.
Sir, good evening, sir. This is Dr. Kiran.
Hi, Kiran.
Thank you so much for a wonderful and very practical and enriching session. With this, I would like to ask the audience to ask questions on the chat, and we can open up the forum and session for discussion. So there is one question from Parimala. If large varicose are left alone, is there any chance that these can lead to malignancy?
Which one?
Sir, Dr. Parimala asks, if large varicose are left alone, is there any possibility of this leading to malignancy?
No. See, the large varicose are present only in 3% of the normal adult men. If left alone, if you don't do any surgery for them, they might over a period of time they might just come down in their androgen production. There may be a hypoandrogenism there, and then there may be associated infertility. But there is definitely no fear of malignancy.
A couple of compliments from Dr. Vijay Bharati. Wonderful talk, sir. Then there's another compliment from Dr. Karpagavani Gurumurthy. Thank you for the wonderful session.
Hi, Asham.
Sir, there's one compliment from Dr. Swapna Chakuri. Excellent and useful session, sir. There is a request from Dr. Vijay Bharati also for a recording of this to be put in YouTube, sir. So, with your permission.
So happy to share.
Yes, sir. Sir, there is a request from Dr. Sunita Pentiala. She says, sir, thank you so much for a wonderful talk. She wants you to explain this medical treatment or medical management once again.
Yeah. So there is a small role of medical management prior to the sperm retrieval techniques. For example, if you have a non-obstructive azoospermia, there are about a couple of medical management you can think of. Number one, you look at the testosterone level. If it is less than 300, you know that there is an hypotestosteronism. Then you look at that testosterone estradiol level. If the level is less than 10, 10:1 ratio, then you know that there is an increased aromatase activity. So what you have to do, you have to use anastrozole 2 milligram daily for about some 30 to 60 days. And then following which, when you do a retrieval, your retrieval chances are better. Supposing if you have the testosterone level, estrogen testosterone level is more than 10, then what actually you have to do is you can use either a clomiphene citrate or an HCG for about 30 days and then just plan for the retrieval. That is one. The third is when there is an increase in DNA fragmentation, which is shown by either one of the methods or by an increase in reactive ROS series, then in that case, there is a role for antioxidants to use minimum for about 30 to 45 days, and then you can just plan for ART, sperm retrieval procedures.
Dr. Kiran?
Yes, sir.
Yeah.
See, I was talking briefly about varicocele. I had opportunity to work under Professor Anne Jacquet. She is andrologist. She has a lot of books and then she has done a lot of publications. So she is the person who trained me in my varicocelectomies, and I was using a lot of varicocele surgeries. Probably around 1,000 I must have done it those days. But when you think in terms of the current revision of the sperm parameters, probably I think that I may be overdoing it at that particular people when it is not wanted. For example, if it is 18 million, today it is normal. 10 years back, it was abnormal. So by looking at that 18 million, we have been doing a varicocelectomies and they have conceived after the surgery. But when you revise the guidelines for the recent parameters, sperm parameters, then probably you think. That is why one of the reasons why all the surgeries and all the techniques, the surgical techniques on the other than the sperm retrievals, they've all gone back. Even if you take this vaso anastomosis following a previous vasectomy, we used to take a 3-0 ethylon straight needle, thread it from one side and thread it through the other side, and then use it as a splint, and we used to do the end-to-end anastomosis using a atoproline. So there, again, the chances of sperm reappearance was, and then that was alone the criteria. But the successful pregnancy was much better, much lower than that of an ART. That is the reason all of them have become obsolete now.
Thank you, sir. Sir, there are a couple of requests from Dr. Aruna Kumari. If you have any video on biopsy and sperm retrieval techniques.
Yeah, I will share it. Just ask them to mail me pmgnath@gmail.com.
Sure, sir.
Ask them to mail me. I will share the videos.
Surely, sir. Sir, the next question is from Dr. Sunita. Is cryopreservation advisable before varicocelectomy, sir?
No, if you're choosing a patient for varicocelectomy, if you do it in a proper way, you're not going to be detrimental to the sperm parameters. So, in case if it is an oligoasthenorteratospermias with a palpable varicocele, when you're just trying to do it, it is worthwhile cryopreserving a sample to see whether you are able to just take a improvement there. If in case by chance if it doesn't improve, we can use it. But normally we do not cryopreserve on a selected patient, on all selected patients where we have taken it for varicocelectomy.
Sir, compliment from Dr. Mamta Agarwal. Excellent session, sir.
Thank you. Thank you. Thank you, Mamta.
Any more questions, sir, doctors? So there are a lot of requests for the webinar link. So we have for the recording. So we will create that and share it with the doctors with your permission, sir.
Sure. Thank you. Thank you all for listening to me, and I'm really honored as a speaker. And my special thanks to Balaji of Shield Healthcare and Dr. Kiran and all of you for making this session a wonderful one.
Sir, on behalf of Shield, I would first like to thank you because I think your passion is teaching. So after so many years also, you still have that passion, and it is so evident in the way you teach the session, and very practical, and at the same time going in deep of each and every aspect of the presentation. So on behalf of the audience and Shield Healthcare, I would like to thank you for sparing your time, and we wish to have many more webinars with you in the days to come. I would also like to thank the audience for logging in this evening for a wonderful.
Thank you.
Thank you, sir. Thank you very much.